Welcome back to our Ultrasound Case of the Month series. As always, email me with any questions or concerns at gzon@iu.edu. This case is unique because it was not evaluated at the academic center. It was evaluated by a recent graduate of our program, Dr. Yvonne Lupo, who currently works in Southern Indiana. Dr. Lupo was working when a 7-year-old male presented for evaluation. The triage vitals are documented and remarkable for tachycardia and a fever of 101.3. The patient was at baseline level of health until he complained of an episode of dysuria, followed soon after by abdominal pain. The patient vomited upon presentation and was found to have an exam remarkable for right lower quadrant tenderness with guarding over McBurney's point. A positive Rossman's and obturator sign were documented. The days of taking a patient to the OR without imaging have very nearly ceased to exist. With that in mind, the treating physician decided to obtain laboratory studies and wanted imaging to confirm his suspicion of acute appendicitis. Ultrasound was selected as the initial imaging study given the patient's age and desire to limit exposure to ionizing radiation. Here are the images obtained by Dr. Lupo. These images are of slightly lower resolution because they were forwarded to me via text. These images were obtained in the right lower quadrant right over the area of maximal tenderness. Like the previous image, we see a tubular structure visualized in a hybrid of short and long axis, which can be common when scanning a nonlinear structure. The dilated tubular non-compressive structure is concerning for acute appendicitis. While difficult to observe, it appears to be blind ending on the left as he fans through. Additionally, we can see fluid outlining the structure and nearby abdominal contents. To help with identification, I highlighted the fluid in blue to assist in appreciation of this subtle finding. An additional cross-sectional view was obtained which displayed a measurement greater than 6 millimeters, the commonly cited upper limit of normal. These images, along with a high clinical suspicion, confirm the diagnosis of appendicitis. Given the age of the patient, the Tertiary Children's Hospital was contacted, who readily accepted the patient for definitive management. Upon arrival to the Children's Hospital, a radiology ultrasound was obtained. The next few images are from the radiology study, which was obtained by the surgery team. This image is a long axis view of the appendix showing a dilated, non-compressible, fluid-filled appendix. I highlighted the appendix in blue to help with identification. The hypoechoic black area outside the appendix represents periappendiceal fluid. Here's another long axis view where color flow was utilized and displayed hyperemia and increased vascularity of the appendix. While this is not seen in all cases, it does add support for the diagnosis. A short axis view of the appendix is displayed. The image on the right is with compression showing no change in the diameter. The pediatric surgeons took the patient to the OR that night, and he was discharged after an uneventful course in the morning, less than 24 hours after his initial ED visit. Dr. Lupo was able to rapidly confirm his suspicions with bedside ultrasound and effectively disposition the patient without waiting on a formal radiology study or without ordering cross-sectional imaging with its increased cost and radiation exposure. As modern medicine gains more comfort with point-of-care ultrasound and images are able to be shared and uploaded in the chart, I feel repeat imaging like was obtained in this case will become less frequent. To further expand your knowledge base on this topic, I wanted to cover 3 specific areas. I'm going to review the classic primary and secondary findings of appendicitis ultrasound and give multiple examples to increase your exposure to what pathology looks like. Additionally, we're going to briefly discuss how good ultrasound is for diagnosing appendicitis. And finally, we are going to review some of the pearls and pitfalls for this imaging modality. Diagnosis of appendicitis in ultrasound is based upon the clinical presentation along with well-described sonographic findings. By far the most important slide of ultrasound findings is represented in this long and short axis view of the patient's appendix. This slide represents nearly everything you need to look for while performing an ultrasound to evaluate for appendicitis. When scanning for appendicitis, you're looking for a dilated, non-compressible, fluid-filled structure. This structure should be blind ending with a diameter of greater than 6 millimeters. The image on the left also displays an appendicolith, which I have marked for easy identification. While the previous slide describes the classic or primary findings of acute appendicitis, the next few slides show secondary findings which can often increase clinical suspicion. This cross-sectional image shows a dilated appendix greater than 6 millimeters with a thickened wall. For the highest accuracy with appendiceal measurements, measure outside wall to outside wall. Additionally, this image shows hypoechoic fluid adjacent to the appendix. To assist with fluid identification, the major collections have been highlighted in blue. This secondary finding is known as the ring of fire. The image shows color Doppler being utilized to highlight the walls of the appendix. Color Doppler is what most of you are familiar with, yet power Doppler can be utilized and is likely more sensitive for this finding. The ring of fire represents hyperemia, inflammation, and increased vascularity of the appendiceal wall. One of the most obvious finds when first learning appendix ultrasound is visualization of the appendicolith. In this video, we can see an appendicolith with its bright echogenic reflective surface with the dark posterior acoustic shadowing. The bright area often serves as a spotlight to draw your eye to the area of concern. The last finding I want to highlight is increased wall thickness. Studies often cite 2 to 3 millimeters, the upper limit of normal, with a measurement of 3 millimeters carrying the highest specificity. Example measurements of the wall and the appendix diameter are included for reference. We have discussed and shown what acute appendicitis looks like on ultrasound and how to make the diagnosis. However, I feel that to display an accurate representation of appendix ultrasound, I need to briefly discuss diagnostic performance. It might surprise some of you that the diagnostic accuracy of ultrasound CT is equivalent. However, the diagnostic accuracy of ultrasound only equals CT if the appendix can be visualized. As many of you practicing clinicians know, visualization is something that is not guaranteed, and non-visualization rates can be nearly 50% in some studies. This is important to appreciate because although a non-visualized appendix might decrease post-test probability, it is not good enough to rule out the diagnosis. As we wrap up our discussion of ultrasound for acute appendicitis, I want to review some of the common pearls and pitfalls. As we previously mentioned, non-visualization of the appendix doesn't alter our post-test probability enough to rule out appendicitis, and farther testing versus joint decision-making needs to take place. Fat absorbs and diffuses the ultrasound beam, making adequate visualization difficult. You can switch to a curvilinear probe to get enough depth, yet I find visualization difficult compared to the high-resolution images offered by the linear probe. While rare, tip appendicitis is a known entity, and as you can imagine, ultrasound does not have a great sensitivity to pick up the specific finding. There are a few pearls worth mentioning that might help increase your diagnostic yield and visualization of the appendix. First, experience does matter and test performance does improve with increased exposure. With that said, I always recommend asking the patient where it hurts most and starting directly over that region. I find that when visualized, the appendix is often seen very near this area. If not visualized, I slowly scan the entire area with a lawnmower technique to ensure the best chance for visualization. If you're having trouble visualizing the appendix, it might be helpful to utilize your non-scanning hand to apply forward pressure on the flank or rotate the patient to left lateral decubitus position. Both have been shown to increase rates of visualization. If I'm still having difficulty with visualization, I next look for the iliopsoas muscle and iliac vessels. The muscle is highlighted in blue and the vessels in red. Identification of these structures helps locate the lateral border of your search area. Additionally, the appendix can be seen just adjacent to these structures, like is shown in this image. Finally, a full bladder can help displace bowel gas and provide an acoustic window that can help with visualization. When evaluating your next patient for appendicitis, take a few minutes to scan the patient. You will be surprised how easily some of these can be visualized. Like in this case, it might allow you to rapidly disposition the patient and get them set up with definitive care. As always, thanks for watching. Email me with any questions or concerns.